And so we are here at the final topic for this year, which is the role of physical therapy in healthcare. That's going to be presented by a friend and colleague, Colin Burke. And so I'm going to go ahead and do this quick review of Colin's background. He's got a BS in exercise physiology from the University of Delaware, where he was a NASA scholar. He has a doctor of physical therapy from Thomas Jefferson University, where he was a Dean Scholarship recipient. He works primarily in Christiana Care's inpatient rehabilitation center and at times floats to acute care floors ranging from the medical surgical floors to the intensive care unit at Wilmington Hospital. In his current role, he is the co-leader of the safety committee for the inpatient rehabilitation staff. It was co-leader of the spinal cord education group in 2021-2022. He is also an LSVT BIG certified, which is a specialized training program proven to be effective in improving movement, amplitude, gait mechanics, and motor control in patients with Parkinson's disease. And Colin, I have to ask, what does LSVT stand for?
I think it's just an abbreviation, and I don't know what it means.
Okay, that's cool. It certainly threw me for a loop there.
Yeah.
Alrighty. So at this point, and then as always, Christy is with us. Normally, Christy does the intro, but I wanted to intro you. So I'm going to real quickly stop share, and I'm going to switch to your presentation. And let me get this all the way to the front slideshow from the beginning. Hold on for just a second. That's better. And screen share. And Colin, the floor is yours.
Thank you so much, Tim. I want to thank Tim and Kate for asking me to speak today. So this will be my presentation on the role of physical therapy in healthcare. Objectives for this presentation are to understand the role of physical therapy in patient management and treatment, being able to describe the education requirements for the doctor of physical therapy programs, gain knowledge of the role of physical therapy in various patient populations and settings, understand physical therapy's role in patient management within the inpatient rehab setting, understand why PTs are integral providers within the interdisciplinary healthcare team. And then at the end, I'm going to review a case study from one of my patients from over this past summer. So the primary role of physical therapy is that we are the movement and mobility experts. We need to be able to identify and treat numerous movement disorders related to physiological pathology. We provide DME or durable medical equipment and assistive device recommendations, and we also write letters of medical necessity for those, depending on the patient's needs. We set specific, measurable, appropriate, realistic, and timely functional mobility goals to address impairments and limitations, and that abbreviation is SMART, SMART goals, which if you end up going into this profession, you'll learn in school. And we also utilize research-based standardized outcome measures for a variety of indications and implications. So the education requirements, kind of everyone wants to know that first off. As of January of 2016, all new physical therapists have to have a doctor of physical therapy degree. Before that, they did have bachelor's and master's programs, and there are transitional programs for those clinicians to get their doctoral degree now. But as long as they have a license, they can still practice. These programs must be accredited by the Commission of Accreditation in Physical Therapy, or CAPTE. So you need to complete a 4-year undergraduate degree, and then these doctor of physical therapy programs are anywhere from 2.5 years to 3 years. And now after that, there's plus or minus additional residency and fellowship programs for after DPT training if you really want to specialize in certain patient populations or certain pathologies. At some schools, they do offer 3+3 programs. So I would look into that if you're really seriously interested in getting into physical therapy. So it kind of gets you through the program a little faster. You graduate during your DPT program. So you finish your credits for your bachelor's during your DPT program, but you get everything done in 6 years as opposed to 6.5 or 7. And then we all have to pass a national licensing exam, and then every state has their own kind of requirements. So you sometimes have to take other classes or pass other tests to practice in certain states. General requirements for admission: you need that bachelor's degree or above. You need a minimum of a 3.0 GPA in all the prerequisite classes, including higher level college science and math courses. You need letters of recommendation. They do require significant volunteer and observation hours. You obviously need a resume. You will go through an interview process no matter where you go. And then certain programs require you to take the GRE, which most students that are trying to get into DPT programs will take the GRE anyway, but some don't. Some programs do not require it. So mean acceptance data from the American Physical Therapy Association for 2021, 2022, the acceptance rate was about 14% for these programs. The average accepted student's GPA was 3.55. The average volunteer time was 275 hours, and average observation time was 560 hours. So really, outside of your curriculum and your bachelor's program, you really need to be doing lots of volunteer and observation hours to really meet the standards for these programs. So I went to Thomas Jefferson University in Philadelphia for my Doctor of Physical Therapy degree, and this is the curriculum there. I just pulled it from there and copied it over. So you'll start with cadaver anatomy, and then some other stuff like that, which is really kind of getting to know the body, getting to know the physiological function of the human body. And then the rest of the beginning year is a lot of intro classes, and then some integrated clinical experiences put in there. And during your second year, Tim, if you want to go forward, you start getting into more of your kind of core courses. So you're thinking like pathophysiology, well, it's pathophysiology 2, but musculoskeletal 1, cardiopulm 1, pharmacology, integ, integumentary system is your skin system, and then neuromuscular physical therapy, and you'll have like certain tracks of those, and you'll have multiple courses over the rest of the curriculum. Also during this, you're working on research. You can keep going, Tim, it's fine. During this, you're working on lots of different research, and you have to have a capstone project finished during the second to last semester. And we presented ours at a national conference in Denver. So they sent us, luckily for us, we went to CMS twice, which is Combined Sections Meeting for Physical Therapy, and it's a national-based APTA regulated meeting, and it's amazing. So we went to Washington and Denver while I was there, and we presented in Denver on our capstone projects. So during that education, you're going to have 128 credits at the end, which is a lot of credits to take in 3 years. It does take basically all of your time up. There's no time to work. There's no time really to have much of a social personal life. Your life is kind of run around this program, which is a good thing, which you needed at that point. It's split between didactic work and clinical rotations. So back on those slides, you don't have to go back, Tim. We do 3 large clinical rotations. At Jefferson, it was 12 weeks, 14 weeks, and 16 weeks. So your last clinical rotation, you are treating for 4 months under a licensed physical therapist. And it's really kind of amazing what you learn in those settings, as long as you're in a good setting. And that's another kind of consideration. You really got to figure out what you want to get into early and then sign up for those rotations, and they can be throughout the country as well. Students will not matriculate if you fail to maintain a GPA of greater than 3.0. If you receive a letter grade of a C in 2 classes throughout the curriculum, they will hold you back. If you receive a letter grade of below a C in any class, and if you fail a clinical competency along with a subsequent retake. And then along with that, if you do not meet new graduate standards during any of the full-time clinical rotations, you will not matriculate to the next year or graduate. So as far as postgraduate residency and fellowship programs, there's presently 412 APTA accredited residency programs and 48 fellowship programs for postgrad DPT graduates. Residency areas can be anywhere from acute care, cardio and palm, clinical electrophysiology, faculty if you want to go into teaching, neurology, oncology, sports, wound management. Fellowship programs are a little bit more specified, so clinical care or critical care, hand therapy. You're thinking more like spine there, sports division one. So if you, or performance arts. So if you want to work like in Las Vegas with dancers or, people that are working in shows all the time or theater in New York, you really want to kind of go to these fellowship programs. So these are also the physical therapy specialties that are offered for board certification by the APTA. So you have cardiopulm, clinical electrophysiology, geriatrics, neurology, oncology, orthopedics, pediatrics, sports, women's health, and wound management. There are also, like, in addition to that, there's lots of other specialty programs outside of APTA accredited programs. Like Tim was alluding to, I am an accredited LSVT big clinician. So, along with speech therapy and occupational therapy, we do provide this service to Parkinson's disease patients, which is research-based, and we have to be reaccredited every 2 years for that to maintain our certification. Another one would be like certified vestibular therapist, who specialize in the evaluation and treatment of vestibular-related pathologies through neurological re-education and or specialized movement techniques. So as far as physical therapy settings, we practice in a variety of patient populations. Not all PTs are the same. So for example, the settings are outpatient home, inpatient or acute, inpatient rehabilitation, early intervention, et cetera. The list could go really on and on. And some of the specialty populations below are geriatrics, pediatrics, oncology, neurology. A lot of the ones that you saw that have those special accreditations as well. So typically patients in the outpatient setting, this is not an exhaustive list, orthopedics, neurological patients, vestibular patients, cardiac patients, pelvic floor specialists, prosthetic training. But a lot of these outpatient clinics can be very specialized. So if you have a neurological insult like a stroke, you'll likely be diverted to a location that can handle that, or clinicians that are more specialized to treat that pathology than somewhere that's more like sports related or pelvic floor related. So it's becoming much more specialized in our profession as well. They generally focus on higher level interventions to maximize community access, safety, or to improve the patient's ability to participate in like a salient activity. So acute and inpatient physical therapy setting is when we're consulted by an attending physician, or residents also consult us due to their concerns with a patient's movement, function, or functional mobility impairments. Typically, qualifying diagnoses will automatically kind of be a red flag where they have to put in a consult for us anyway. So stroke patients, amputees, multiple falls will automatically get consulted by them. And that's kind of what I went into a little bit below there. The role of for us in this setting is to assess mobility level, and then is the patient safe to discharge? And then also, if they are safe to discharge, what level of care do they need afterwards, and what DME, durable home medical equipment, they may need to get home safely. We also can, like Tim was alluding to earlier, work on specific floors or float between floors depending on the hospital setting. And we also will work with the nursing staff to recommend in-room or on-unit mobility when they're not working with us. So the rehabilitation setting can kind of span the patient's healing time from acute to chronic. And we recommend We make recommendations for different level of care dependent on the diagnosis, prior level of function, age, endurance level, past medical history, family support, home setup, current mobility level, and severity of deficits. We're thinking about all of these things when we're chart reviewing before we're seeing a patient and then while we're seeing a patient. And we're trying to gather as much information as possible while we're seeing a patient, because if we're going to make a recommendation for rehab, these are the 4 rehab centers that we would likely recommend, and we need to discuss that with case management and the attending physician. So 1 would be an inpatient rehab facility, 2 would be subacute rehab facility, 3 would be a skilled nursing facility, and 4 is a long-term acute care facility. And that's going from highest to lowest in level of intensity of therapy. So this is where I work in an inpatient rehab facility, and I work at Wilmington Hospital. It's one of only 2 in the state right now. I think there's a 3rd one being built a little bit more south, but we're one of the 2 in the state. There's a lot in Pennsylvania and in Philadelphia, but it's the highest intensity of all therapy settings, with a requirement of 3 hours of therapy a day for 5 days a week at least. Most patients must have a qualifying medical diagnosis, and they must require daily medical oversight and at least 2 of the 3 therapy needs. And generally it's PT/OT, and then speech is an add-on. But we do get patients that are very aphasic or dysphagic, and then they require maybe 2. The speech therapist will take 1 more session from us daily. They must be able to tolerate the intensity of therapy. So when we're seeing them on acute care, we want to make sure that they can do that 3 hours of therapy a day for 5 days a week at least, because if they do not meet the requirements, it's really a situation where then they need to move to another level of care. The disposition, so where they're going after they leave, must include accessible housing and or caregiver assistance, supervision, depending on the prognosis for the patient. We see more acute than subacute patients, but we do have subacute patients, and we do sometimes get chronic patients as well. So for subacute rehabs, the patients will generally get an hour of therapy a day, 5 days a week, which is still a high intensity. If you're thinking about an outpatient clinical setting, they're generally being seen 2 to 3 times a week for 30 to 45 minutes, sometimes upwards of an hour, but it's nowhere near being seen 5 days a week. And also they're living in these facilities with nursing care. They'll likely remain in these facilities longer, and insurance pays for longer stays. So this is appropriate for patients with longer healing time, or increased functional mobility deficits or impairments. These patients are typically a little bit more medically stable too. They do have a medical team there, but they're not generally on site at a hospital. So they can't get to, emergent care rapidly like we can. We can go right to our ICU, which is on the same floor as us, within, minutes. So a little bit below that is the skilled nursing facility. So this is a mild level of intensity of rehab with varying frequency and duration of therapy, depending on the medical diagnosis and level of impairment. The medical condition that they do have requires a visit by a physician at least every 60 days, and constantly available skilled nursing services. So they do have nursing services there, but they don't necessarily always have an MD there or physician oversight. They can be more long-term or destination care depending on the diagnosis and patient need. LTACs, or long-term acute care centers. These patients have more immediate medical needs than therapy needs, generally the most medically complex, often requiring respiratory support and constant nursing and medical oversight. PT's role in these settings is largely dependent on the patient diagnosis, prognosis, tolerance to therapy, medical stability, and the medical goals of care instead of the PT goals of care. So there's a whole lot of other specialty rehabilitation centers. You think dementia wards, burn centers, palliative care, and the role and goals of PT will highly be dependent on the medical care goals, diagnosis, and prognosis, just kind of like the previous slides. So the sports therapy setting, which is kind of like the complete opposite of what I do, PTs can work directly with athletes at a high school, college, or professional level to rehabilitate from injury. They can work as prophylaxis for injury or preventative for injury. And they can also work on physical preparedness for sport. So think like preseason training, stuff like that. During the season, which I have a twin brother who works as a PT as well, and is more sports based. He's done this before. You can work as kind of a primary provider during games to assist with diagnosis and treatment of orthopedic injuries during those games. There's also a number of well-known PTs who work with some of the best professional athletes in the US and in the world. I follow a bunch of them on Instagram and social media. It's pretty amazing the work that they do. Another setting could be early intervention or pediatrics. So the goal of therapy is to meet established developmental milestones, maximize mobility for appropriate age-related interaction, improve ability to access home, school, and community environments. The goals are highly dependent, again, on diagnosis and prognosis, along with the child and family needs. And we also, in that setting, order appropriate durable medical equipment. Interestingly enough, in the military, physical therapists have much more of an autonomous role. So you have to be an active member of the military, but you can work in a variety of settings, just like the settings I was talking about, but they'd be federally funded. We have the ability to order radiographs in those settings, so x-rays, MRIs, CTs, and they also receive special training to prescribe certain medications. So like in the education piece, we go through a pharmacology class, but we do not prescribe medications. In the military, you can. So back to the inpatient rehab facility where I practice. This is ours specific at Wilmington Hospital. We have 2 attending physicians. One is our medical director, 6 full-time physical therapists, 6 full-time occupational therapists, 2 full-time speech therapists, full-time nursing staff, along with patient care technicians, which assist the nursing staff, 1 recreational therapist, 1 neuropsychologist, 2 case managers, and then we have 1 social worker who also covers additional floors at Wilmington Hospital. So I'm one of those 6 physical therapists there, and the following are the 4 most common admitting diagnoses, and the diagnoses that we can admit, especially from an insurance standpoint, pretty readily and pretty easily. So cerebral vascular accident is another name for a stroke. It can either be ischemic or hemorrhagic, meaning it's a lack of blood flow or there is a bleed in the brain. Spinal cord injury, traumatic versus non-traumatic. I'm assuming most people know what a traumatic spinal cord injury is, but a non-traumatic spinal cord injury would be something that's acquired, like a brain tumor that's resectioned or something like that. And then brain injury, acquired versus traumatic. And then we do have a lot of amputees, primarily transtibial or below the knee, or transfemoral or above the knee. Although we do get transmetatarsal, and that means all of the toes are gone. Hip disarticulations, where they take off the whole leg, or upper extremity amputations. These are additional common admitting diagnoses that we get. So for cardiac patients, we get status post CABG or coronary artery bypass graft. LVADs, which is in the depiction on the side of the screen, those are left ventricular assisted devices. They're essentially powering the heart. And those, I could go into a whole lecture on LVADs, but those are pretty interesting devices. And then sort of aneurysm repairs, things like that. The next kind of construct there would be the multiple major trauma. And those are people, gunshot wounds, motor vehicle accidents, fall from heights. There's usually multiple orthopedic injuries and lots of medical needs. From an orthopedic perspective, we generally see hip fractures a lot, spinal surgeries, joint replacements not as often anymore. They do want to get joint replacements out the door pretty quickly. So knees and hips don't come up to us unless there's some other type of issue going on, like advanced Parkinson's, dementia, some type of infection, or they had to do a lot of revisions. And then we do see a lot of medical debility patients. It's often associated with a more prolonged acute care course. So we do see them more on like the subacute or chronic side. And during COVID, we saw lots and lots of COVID patients after their prolonged recovery. Septic shock, so people that have gone into where their organs are failing and they need to be in the ICU for a prolonged period of time. Respiratory failure, either they're intubated or trached to maintain their life at that point. And then we do see a lot of organ transplants with acute or chronic complications. These are two other additional ones that we see a lot. So prosthetic training, these patients will come from home. So they get fitted for their prosthetics. They get their prosthetics from the provider, and then they come to us to learn on how to use it, skin management, prosthetic management, donning and doffing the prosthetic, how it functions, how to perform all their kind of daily living tasks while they're using their prosthetic. But those are the only patients that'll come from home to come see us generally. And then other neurological conditions, Guillain-Barré syndrome, multiple sclerosis, ALS. We have had a couple West Nile patients, and then Parkinson's disease, like I mentioned before. Almost invariably, these patients have numerous comorbidities and other additional medical complications, in addition to the diagnosis that they're being admitted for. There's very, very sick people out there, I will say that. And so we're dealing with a lot of things when we're seeing these patients, and we're being considerate of lots of different aspects of their health while we're treating them. But IRS days have been proven to decrease hospital readmission rates, maximize patient functional mobility, independence, and safety, while also decreasing the burden that it would be if the caregiver would take the patient home from the hospital like they have before we were available for them. So these are kind of how we bill insurance companies. There's different interventions that we do for most of the patients we see in an IRF setting. We're billing 90 minutes. So we're seeing them in two 45-minute settings in our setting, usually one in the morning, usually one in the afternoon, unless we want to change that up a little bit. So we'll be billing on those 90 minutes and 6 units under these certain constructs. So therapeutic activities are mobility activities that are generally pertinent to safe discharge from this setting. So think functional transfers, bed mobility, wheelchair mobility, etc. Gait training, we want to assess gait impairments in a variety of ways to maximize mechanics, use of an assistive device, make orthopedic recommendations, stair navigation ability, and then progressing gait to maybe going out into our healing garden or going to a different area of the hospital where there's ramps or something like that, so we can simulate them getting home and outside more. For neuromuscular reeducation, we're thinking interventions to generally promote neuroplasticity related to gait, balance, and mobility. And then the two other ones we have are therapeutic exercise, and the goal is to address musculoskeletal strength and endurance deficits. For carryover, like the goal would always be for carryover to improve performance of functional mobility tasks in our setting, at least. As far as manual therapy, generally it's not performed that much in the IRF setting unless there's the presence of contractures or for tone management. And tone is generally something that occurs after an acute brain injury. So we do see it. But for contractures, you do want low load, prolonged stretching. So we try to teach the patient, we might stretch them initially and then give them the ability to do it when they're back in their hospital room, because they really need to do it for a long period of time throughout the day to see effective outcomes. We do perform lymphatic massage at times when appropriate. Oh, and for our new amputees, Tim, you don't have to go back. We do all the wound care in this setting as well. So the nurses don't do the wound care. We do all the wound care, and we teach the patient how to do all their wound care for the new amputees. So specialized equipment we have and interventions in IRF setting. We do have specialized treadmill training with an overhead lift support. Our program uses the Biodex Gait Trainer 3, which provides audio and visual biofeedback about step length and step speed. It'll track general statistics like speed, duration of ambulation, and distance, but it also has the ability to track more specific statistics for us, like average step length at each leg, the coefficient of variation or percentage of variation of step length and width at each leg, and time spent in stance on each leg. And these statistics give us and the patient more information related to how they're walking or how they're moving, and then how consistent their gait mechanics are becoming. So that is a depiction of the one that we use on the right-hand side of the screen. It does have an interchangeable seat on ours, so there's not 2 seats, there's just one, and it can be removable to the other side. It does have removable arms and handles too. The overhead lift capacity we use frequently with our patients, because generally we have a lower level of patients anyway. If you do have higher level patients, you can use this as well, and you can use it without the harness. You can also pull the top part off. You can just unbrake all the wheels, pull it off, and you can do higher level balance stuff with them in the overhead lift, which is pretty cool as well. So research demonstrates that treadmill training post-acute or subacute stroke can generally improve gait speed, endurance, and gait mechanics compared to standardized overground training alone. So I'm going to go into some equipment that we don't have and some equipment that we do have. So a Locomat is a very expensive piece of equipment for gait training on a treadmill, but the device provides a significant amount of assistance to complete assistance for the patient to perform some walking or ambulation. The pros of this is you can perform it at an increased intensity because we're not having to provide a lot of assistance or help or facilitation during the training. And it keeps the gait pattern very consistent throughout because there's multiple points of contact. If you look at a picture, they're strapped in a lot of different places, and that machine's just essentially walking for them. There is the cons to this is a long setup time. We need to get specialized training to utilize it effectively. It does not allow for much error, which I alluded to, and it's very expensive, around $500,000 actually for this piece of equipment. So it's not as functional as you necessarily would want it, but it is very good for certain patient populations. So functional electrical stimulation, we do use at our rehab center. We use the BioNS L300 Plus system, which is in the depiction on the right as well. This device is indicated for patients with lower extremity weakness, typically stroke, MS, cerebral palsy, traumatic brain injury, incomplete spinal cord injury, et cetera. I mean, we use it with a lot of different patients, as long as it's indicated, because there's a lot of good benefits to it, which I'll get into. It comes with a controller like an iPad, and we do all our training in-house. We have, we all very versed in it, and if we do have problems with it, there's one point person that's kind of specialized in it if we want to kind of really adjust things or make some different changes that we don't necessarily use with every patient. And BioNS devices are clinically proven with the ability to increase range of motion and reduce risk of falls while improving confidence and independence in patients that utilize them. There's also FES bikes, so functional e-stim bikes. We do not have one of these, although we are looking into purchasing one of these. Pros are that the patient can train in a reciprocal pattern at a higher intensity over a longer period of time, kind of like the Locomat before. It gives a lot of input to the central nervous system related to appropriate musculoskeletal contractions, just like the BioNS I discussed before, but this has more points of contact throughout the leg. And there's also a device called the Excite, I believe, that has arm controls along with the bike, along with the leg setup. The cons are it does take a long time to set up because of all those points of contact. It's an expensive piece of equipment, and research is telling us that they need to be performing it for a long duration. So a lot of places like McGee and Moss and Bryn Mawr that utilize this actually have programs where not PTs, but other aides will set the patients up on these for like an hour or so before their therapy sessions. So some contraindications, you can read through these, you don't necessarily need to know these, but some additional benefits that I really wanted to kind of relay in this PowerPoint are we provide that stimulating motor contraction at an appropriate time within the gait cycle. So our BioNS system, there's a thigh pad and a lower leg pad, and it is causing ankle dorsiflexion and knee extension during the correct time in their gait pattern by using the iPad. It gives that intrinsic feedback through vibration as well, and the stim sensation itself, as long as the patient's intact from a sensation perspective. And then as far as extrinsic feedback, it will provide auditory beeps when the cuffs are turned on. Exoskeletons, you've probably seen a lot of this if you've been interested in this profession at all. They can be used in the presence of complete spinal cord injury. So ASIA A spinal cord injuries, where they do not have any sensation below their level of injury, They can be used in patients such as ALS, where they are losing a lot of function. It is beneficial for all the physiological functions that you get when you're standing or you're walking. But the cons are it's not very practical, as exos need to be generally controlled or set up by us for the patient to use them. If you do see, patients use these to walk across the stage during graduation, you will see a PT behind them usually facilitating it, or at least on the stage to make sure everything's going okay. We do get specialized training if we're going to utilize these. We do not have these at Wilmington Hospital, and they are very, very expensive. So orthotics, we utilize a lot. We work directly with orthotic companies in the local area for AFOs, or ankle foot orthoses, knee braces, shoe wear modifications, etc. We have a number of off-the-shelf carbon fiber AFOs at our rehab center. So if we're thinking we're going to trial something with somebody, we can try different ones, different sizes. We can see what works, what we want to really adjust with the patient to make their walking safer and more effective, and then really practice with that until they get it. Because oftentimes insurance companies will not provide it until it's closer to their discharge date. And then they won't be able to utilize it unless we have the loaner ones. And then prosthetics, like I kind of got into a little bit more. We work with a number of local prosthetic companies as well. For below knee prosthetics, we're thinking about various suspensions, and how the prosthetic sticks to the leg is what a suspension is. And the socket is kind of how it fits around the residual limb. And then the ankles and the foot can be different depending on the patient's K level. And the K level is, that could be a whole other topic, but the K level is how mobile or how functional they are before they get the prosthetic. So, and then for above knee prosthetics, in addition to the suspension sockets and the ankle and feet, we're thinking really about the knee joint and how the patient's going to function with the knee joint provided to them, depending on their K level. We want to think about their hip mobility, wear tolerance, trunk control, and then the opposite leg's strength and function. So we're going to go into some devices that we do have as well. The Ever Walker is one that we just recently got. So it's a bilateral forearm walker, and it's generally used with patients with poor trunk control, or they have non-weight bearing restrictions at the wrists. You sometimes hear about this as a cardiac walker because it is on a lot of cardiac floors as well. Because when they do a median sternotomy to do a CABG or a coronary bypass procedure, or any other type of procedure where they need to get to the heart quickly and they cut the breastbone open, patients don't really tolerate pushing down well, and they can't really do a lot of pushing. So this type of walker is really, really indicated for them. We do use tilt and space wheelchairs a lot as well, and it's very, very beneficial for patients with decreased trunk control, decreased sensation. So if you have somebody that can't off weight themselves, you are automatically thinking about pressure injuries. And if they can't feel that they're sitting somewhere for too long, they won't move. And that the bony prominence generally creates a pressure injury at the skin level. And then you end up with lots of problems. So people with, sensory issues, we generally get in tilt and space first. Tilt and spaces work first, come up with a plan with the nursing staff to tilt them every 30 minutes or so. And then also people with poor safety in a regular manual wheelchair, more your severe brain injury patients in that case, where they're more impulsive and they're doing things unsafe because they just don't know that it's unsafe for them. The cognitive impairments are limiting them from being safe. And then lightweight wheelchairs, these are our K5 wheelchairs, and these are the wheelchairs we order for patients that are going to be primarily wheelchair users upon discharge, and we can really customize these wheelchairs for our patients. So like I said, we do have to write letters of medical necessity for all manual wheelchairs and all other DME orders, and one of our attending physicians will sign off on this prior to the patient obtaining the equipment, and then our case managers run it through their insurance companies. Something to be really considerate about, though, is prognosis for the patient, because insurers only cover one mobility device every 5 years for adults. Pediatrics is completely different. They do it pretty, I think it's a little bit more lenient in that regard, but they still have problems with getting mobility devices changed out and new mobility devices as well. So really we wanted to get them to the highest level of function before we order anything for them. So goals for physical therapy. We want to write mobility level goals that are specific to the patient, injury, diagnosis, and prognosis. For higher level patients, think household, community distance walking, community distance mobility, and then plus or minus a least restrictive assisted device. So walker, cane, crutches, wide base quad cane, something like that. And then for our low level patients, we're thinking either wheelchair level goals or a combination of standing base goals, but like short term, like household distance standing base goals, and wheelchair level goals, depending on where they fall on that recovery versus compensation spectrum. So as far as IRF settings, Medicare has mandated that we kind of always capture quality indicators. And these are what we'll be capturing at evaluation, progress notes, so every 7 to 10 days, and then at their discharge. And what they want us to try to do with the patients, if it's appropriate, is walk 10 feet, 50 feet with 2 turns, 150 feet, walk 10 feet over an uneven surface, stairs 1, 4, and 12. And it could be 4-inch stairs, which is not appropriate, not generally appropriate or consistent with household distance stairs, or 6-inch stairs, which is more appropriate with and consistent with household stairs. And then bed to chair transfers, car transfers, object retrieval from floor and standing, wheelchair mobility, and then also bed mobility, which isn't on there. And then they're scored based on the assistance level needed during the activity. And so there's a little breakdown there, and I go a little bit more into it on the next slide. So if the patient requires 2-person assist or a wheelchair follow, it's scored as dependent, or a score of 1. So if there's a wheelchair follow at all for safety, or you're too concerned that they're requiring too much assistance, they can't turn around, something like that, it's not functional for the patient to have a wheelchair behind them unless they're like Tony Stark. So it's not practical, so it needs to be scored as such. If the activity was not performed due to safety concerns, symptoms, or functional level, the patient's functional level, the item is scored as not medically safe to perform, or an 88, which does happen pretty frequently. If the patient declines or refuses to perform one of the items, and the PT believes that they can complete it, it could be scored as refused. We don't generally do that too often, and that's a score of a 7. And then if the functional activity was not performed prior, and there's no anticipated goals for the activity, it can be scored as not performed prior, which we do typically with manual wheelchair level mobility. But this could also be stairs, ambulation distance, depending on the prior level of function, and that's scored as a 9. If there's other environmental limitations to assessing the functional activities, which we encountered a lot during COVID, because we were either in their room or later when we were getting lots of COVID patients, we created a COVID gym in one of our larger hospital rooms, but it still limited us from capturing some certain things. We could score it as a 10. If there's not enough time to complete the functional task, it's scored as a did not occur, and the plan is always to capture this item within 72 hours of the time that they got there, or prior to discharge. These QI scores, like I said, are taken at these specific times with the patient and then submitted to the patient's insurance company. We do meet weekly for team conference to review every patient and their progress. And we will be there from a therapy perspective. Nursing will be there, neuropsychology will be there, the MD, the doctor will be there, case management will be there. And now social work's been coming for the past about 3 months. She would just get kind of the notes about if she needed to do something, but now she's actually been present, which is great for us as well. And we're there to discuss the tentative discharge date, with an update sent to the insurance company, and then also like what other needs or barriers does the patient have to getting home. Length of stay is approved by the insurance company. It's highly dependent on the scores that we score at their initial evaluation, and then at these progress note intervals. And most insurance companies, just like with any other type of healthcare, follow what Medicare approves or what Medicare does. The goals can include caregiver assistance or supervision, depending on the diagnosis and prognosis. So generally those with baseline or progressive or newly acquired cognitive impairments are going to require some level of supervision upon discharge. So we got to be considerate of that at our evaluation as well. And then those with profound deficits or our lower level patients, we always want to think about if they're going to require some type of assistance or supervision at discharge. The goals can always be upgraded or downgraded based on progress or caregiver availability or the caregiver physical ability. And family trainings will be scheduled and occur pretty frequently with lower level patients. With higher level patients, it can be a situation where, you know, if family's not there every day, which sometimes our patients have family with them every day, sometimes they don't. It will be scheduled with one of the caregivers that will be with them when they're discharged, and will provide education and then practice for what the goals were. At the end of a stay, all the patients are given the opportunity to do a victory lap. So it's a kind of a last walk, and we invite kind of our whole team to come to them, depending on the patient, and we cheer for them. They're very emotional at times, especially for our long stay patients. They'll select the song, and then we all cheer for them, and we have bells and the whole nine. And then we'll select kind of the level of mobility, whether it be standing based or wheelchair based, and then what level of assistance or supervision. Generally, if the family's already trained and they're doing their victory lap, we just let the family member do it with them and bring the wheelchair back behind them after they're done their walk. So this is my case study about a patient that I saw this summer. She gave me permission to do this case study on her for you guys. So she's a 46-year-old female. She presented to Christiana Hospital on July 22nd of this past summer with acute symptoms including headache, slurred speech, left-sided weakness, nausea, and vomiting. She was found to be hypertensive, dysarthric, and she had a very high NIHSS score during the ED workup. She had significant nausea and secretions, so she was sedated and intubated pretty quickly. And the CT of her head revealed an acute pontine hemorrhage. So she had a bleed in her pons, or an area of the brainstem. And she was admitted to the neurological critical care unit. So the pons, or bridge in Latin, is an area of the brainstem primarily responsible for communication between the cerebellum and the forebrain. So a lot of like basic life functions and a lot of coordination, where the brain is or where the head is in space, those type of things is what you're thinking about when you have a patient with a pons infarct. Also, in addition to breathing, sleep, wake cycles, sensory interpretation, there's 4 cranial nerves that are that start from the pons area. So generally, they're going to have some problems related to these cranial nerves, and this patient did have quite a few related to these cranial nerves. So as far as her neurological critical care stay, she remained intubated for airway protection and respiratory support initially. She was noted to have a PE, or pulmonary embolism, which is a clot that has come from another area of the body or the heart and has gone into the lungs. Does cause problems with respiratory rate control, the ability to appropriately ventilate in the lungs. On the 27th of July, they tried to extubate her, but she failed due to a decline in managing her secretions and then a respiratory problem called stridor. Due to that, they did a percutaneous tracheostomy. So they put a trach in, which is in the image on the side, and they gave her a PEG tube for nutrition. So that goes, it's percutaneous and goes into the stomach, and then they can kind of pump in food. A FEES, or an esophageal imaging, was done, and ENT noted that our left vocal cord was paralyzed and the right cord was swollen with a 1 millimeter polyp. Speeding forward a little bit, because she was pretty impaired, and I'll go into kind of the PT workup for that. On August 16th, vascular was consulted because she had a left calf deep vein thrombosis, which is a clot in her leg. So we want to get vascular on board whenever there's a deep vein thrombosis, because the risk is that that clot dislodges, comes up to the heart, and then goes into the lungs and causes another pulmonary embolism. So on the 18th, they started decannulation protocol. She was downgraded from a 6 to a 4 in trach size. Unfortunately, later that day, the trach dislodged during turning for perihygiene. She became kyanotic, which means she was blue. A code blue was called for cardiac arrest. She underwent 2 rounds of CPR before they were able to achieve spontaneous circulation again. And then the trach was replaced. Although rhythmically her heart was pulseless from electrical activity, and that's what runs our heart, so that's a big problem. So she was ventilated immediately and transferred to the MICU. On the 19th, so a day later, she was able to be weaned from the ventilator and transferred to the pulmonary step down, so that's great. This is very unfortunate. You don't want this to happen. Generally, with patients that do have code blues and cardiac arrests, you have to think about anoxic brain injuries, or because there is generally a period of time where the patient's brain has not received oxygen. But because she was at the hospital immediately, she did not have a lot of cognitive impairments as a result of this, if any at all. I probably would say she had not. She's a very funny and awesome woman. So on the 21st, they put in an IVC filter for the left half vein thrombosis. So that's the inner vena cava, and that's the main artery that comes back into the heart from your lower body. So they put a filter there just in case that clot dislodges, it'll get caught in the filter instead of getting into the heart. And that was Vascular's decision. And then on September 5th, she was transferred to us. So during her acute care stay, PT was obviously following her. So 2 days after she was admitted, PT was consulted and the evaluation was completed. The subjective information was taken from the husband because she was intubated. She was found that she was independent, living in a 2-story house with her spouse, was working full-time as a medical assistant, actually for one of our orthopedic surgeons. Her primary bedroom and bathroom were located on the 2nd floor of her house. She had 7 steps to enter with both handrails, and then 12 steps inside to the 2nd floor with the right handrail only. That info was obtained by me later on. She was subsequently found to have visual deficits, including diplopia, which is double vision, and blurry vision, dizziness, nausea, and episodes of vomiting. And this is all related to the location of the stroke in the pons area. So this is how PTs and doctors score your muscle strength, a manual muscle test or MMT scores. The higher the score, the stronger you are. So 0 is no palpable movement at all. And it kind of goes up from there. 1, you can, like, the muscle contracts, but there's no motion at the joint. And then it goes all the way up to 5, where I'm really cranking on you and I can't move your limb at all. So this was her on her initial examination in the acute care setting. You can see on the right side, she's pretty strong, not great, but pretty strong. And on the left, at the hip and at the knee, not strong at all. So she was not able to move through any active range of motion at the knee. At the hip, she was able to get through less than half of the available range of motion. And then at the ankle, she was stronger. She could get through against gravity in both directions. And then as far as light touch, it was impaired on the left and intact on the right. The assessment was limited by the oral intubation, and also she had elevated BP. The hold parameter was a systolic blood pressure of less than 150. And if I believe so, once they got her up and moving, it went through the roof. So the mobility assessment during that was just rolling and scooting in bed, and she was dependent or total assist for that. Throughout the rest of her stay, they were able to work on bed mobility and sitting balance, but it was required max assist to total assist. So max assist is you're giving a lot of the effort. Let me go through that real quick. So contact guard means I'm just holding on to them, but I'm not doing anything. Min assist is 1% to 25% of the patient's volitional or me having to help the patient volitionally. And then 25 to 50 is mod assist. 50 to 75 is max assist, and anything over 75% is dependent. So if I have to do more than 75% of what you can do to get the motion or activity done, you're a dependent patient at that point. Now getting closer to when she was discharged to us, they were able to do one sit to stand transition, but it was a max assist of 2 with a left knee block. So they were blocking the knee into extension when they were standing her up. So on the 5th, she was admitted to us. The evaluation was performed by me. She did have the ongoing double vision, dizziness, nausea, and vomiting. An eye patch was applied by OT, and we alternated eyes each day to improve visual convergence. She unfortunately had just vomited during OT when I got to her. And you can see, you know, her BP was a little elevated. But heart rate was okay. It's close to tachycardic. It's within the normal range of 60 to 100 beats per minute. And her oxygen saturation was fine at 95%. She did have another episode of vomiting at the end of our session, and her BP was elevated, but within kind of the same range. So this is the kind of objective measures on my evaluation. See, she got a little stronger on the right. I mean, I imagine from working with PT as well. And then on the left, much stronger than when she was initially evaluated. So the brain was already healing, or the messages that were traveling through the pons were getting through a little bit better, so the muscles could activate. As far as sensation, I did a little bit more of an extensive evaluation, and we found more impairments in proprioception and coordination on the left side as well. And proprioception is how your brain knows where your joint is in space. So if you don't look at your ankle right now and you pull your ankle up, you know your ankle is in an up position. If your proprioception is impaired, you might not know where that ankle is in space. And she had that on her whole left side, like impairment. So my mobility assessment initially, she was a max assist for laying down to sitting up. Rolling, she did okay with, although she needed a verbal cue. So I was still providing close supervision so she didn't roll off the side of the bed. And then sitting to laying down was a max assist as well. And I was helping with trunk management and both her legs. As far as transfers, we tried a low pivot transfer to the right. So generally you want to go to the strong side or the intact side with a stroke patient. It's easier for them to move. They know where they're going. They can be more involved in the transfer. So I was blocking the left knee, providing support below her ischial tuberosities or her butt, and at the trunk. And we did it all in one bump. But it was me and a rehab aide providing that up to 75, I would say 75% assist to complete that task safely. And then during her sitting balance, she had really poor trunk control. So it was a min to mod assist. And it would vary from leaning back, leaning forward, leaning to the side. She really couldn't control where her trunk would go. And we were able to get one partial sit to stand done. We have a hemibar, which is kind of a long oval that our patients can pull on, or we can do exercises where they can support themselves with their arms. But she required lots of verbal cues for sequencing and positioning prior to the attempt. She was a max assist to me for that left knee block or left knee stability, left hip extension, and then trunk control. And then I had my rehab assistant or rehab aide inside the oval, and she was assisting with trunk control and hip extension at a max assist level as well. As far as wheelchair level mobility, we want to think about what's going to be the most functional for her. And because she's so impaired on the left side, we go directly to hemi-propelling, or propelling with one side of the body only. So right arm, right leg, she was able to do 150 feet, which is great. She did require min assist from me to maintain momentum and steer. I didn't have this in here, but she was a little inattentive to things on the left-hand side, which was one of my concerns as well. As far as parts management, she required min assists for the left brake. You always want to consider that with somebody initially who's a lower level patient like this, immediately getting started training them on how to manage a wheelchair themselves, because the goal would be for them to do as much independently as possible. So she was able to manage the right brake and the right armrest with supervision and some verbal cues. She had decreased tolerance to be sitting upright and standing, dizziness and double vision throughout the evaluation. I did put her in a tilt and space wheelchair as a result, so we could improve pressure relief and also improve her upright tolerance. So while she's sitting in the hospital room with nursing, they can tilt her up for 5, 10, 15, 20 minutes, and then bring her back down if she's not feeling as well. So she did vomit again. And you always want to think about with a trach patient, aspiration or the risk of a foreign object going down into the lungs. So for her, because the trach was there, if the vomit comes up and doesn't get out of the mouth forward, it can go back down into the lungs and she can end up with pneumonia or some type of respiratory issue. So we always wanted to keep her in an upright position while she was vomiting, which means we were very close to vomit a lot and almost got it on us quite a bit. So as far as short-term goals, I made goals for around 2 weeks for short-term goals. And this is because insurance companies generally don't like patients to be in an IRF setting for longer than 4 to 6 weeks. Generally, they would go to subacute rehabs if that's the case. Although we really start helping facilitate their stay with us once we get around that 4-week mark, and we do weekly updates that we send to the insurance company to get another week every time, if we can get another week every time. So I wrote kind of more realistic goals. She probably would have benefited, especially the long-term goals, with a longer period of time, and that's why I added a little plus, which we'll get to. So more importantly are the long-term goals. What is she going to look like when she leaves, right? So 4+ weeks was what I was thinking. And I was really thinking around like 6, 7 weeks for this particular patient. So she would be independent or modified independent with all her bed mobility, plus or minus the bed rails. I was thinking about ordering a hospital bed because she only had the one handrail to get up to the second floor to her bedroom. So you want to be considerate of the home environment already. And if she's just going to kind of live on a first floor setup, which was what she ended up leaving with. Wheelchair level transfers, we want her to be at a modified independent level. Standing based transfers with a least restrictive assisted device, we want her to be at contact guard. So her husband, her spouse, was going to be providing that guarding at discharge. Walking at least household distances with a least restrictive assisted device at a contact guard level. She would be able to propel herself independently, manage all her wheelchair parts, then the 12 stairs to get into it. So you got to think about getting into and out of the house with both handrails at a min-assist level. And then we're going to perform caregiver training no matter what. And then home exercise program and durable medical equipment provisions. So this was my assessment that I wrote at the end of my evaluation, at the end of the day. So she presented with moderate to severe left-sided strength deficits, left inattention, decreased left sensation, poor trunk control, decreased left-sided motor planning and control, decreased left-sided coordination, decreased tolerance to upright, visual deficits, and decreased endurance activity tolerance. And these are maximally limiting her overall functional ability. I went into a little bit about how she moved and then like her spouse and discharge. And then for her, she would have a fair potential because of her age, the severity of her deficits, the left lower extremity strength. So she was a little strong, which was much more stronger than initially than the initial evaluation. And then also her prior level of function. She was very active in getting around before this. And then we always kind of want to tell insurance why the patient would benefit from skilled PT. And if you ever get into this profession, you're going to be writing lots and lots of notes. So we do keep lots of like templates or things that we want to add on to make sure we're covering, what the patient needs. So as far as the plan, the frequency is always 5 to 7 times per week with our patients, and the duration was 4+ weeks. The initial considerations are airway protection. Always remain aware of where the trach was. You do not want it to dislodge again. You do not want a code blue to be called, obviously. And the aspiration risk with the secretions and the vomiting. So she did require some suctioning earlier on, but she was able to be weaned. We need to initially, and that's what I wanted to do, immediately gradually build tolerance to being upright while also mitigating the nausea and vomiting. And then we get our doctors on board to really help us out with medical management. So she was put on an anti-anemic called aldosterone or Zofran. and that was as needed. So if she felt nauseous, they would give it to her. It's a sublingual, so it's under the tongue and it dissolves. And then a daily sclodipine patch, which is for dizziness. And then input, input, input. We want to optimize neuro recovery. So we want to give the left side as much input about where it is in space as possible. And that's with every intervention you're thinking of generally. And then durable home medical equipment, I wanted to think about initially as well. So I thought she would benefit from a custom K5 manual wheelchair, some type of ankle foot orthosis, because, and I'll get into this, when she was walking, she was hyperextending at the knee a lot, which was throwing her off at the trunk and was causing a lot of gait issues and safety issues. Possibly a hospital bed, and then some type of leash restricted assistive device. So these are the principles of neuroplasticity from Kleinman Jones's research from 2008. And this is what we're thinking about with all of our patients that have central nervous system or peripheral nervous system injuries. So use it or lose it, use it and improve it, specificity, repetition matters, intensity matters, time matters, salience matters, age matters, transference, and interference. And these have been found to be pivotal kind of stepstones in making or building new changes within the brain or the central nervous system to allow for return of function or an adjustment in the brain to cover or maintain function in a different way. So as far as progression of interventions, I'm just going, this is kind of like week 1, week 2. We were working on building tolerance to upright in a tilt and space chair, and that is a tilt and space chair over to the right. And then we would get her in the standing frame, do some gait training in our overhead harness system, which we have as well. And then get her tilted upright in the room for activities of daily living as much as possible. She did continue to have bouts of dizziness and nausea and vomiting. It did gradually improve over time. We really focused on wheelchair level transfers at first as well. She continued to require 2-person assists, although her sitting balance was getting better and better because she was getting up more. On the acute care side, you'll find that the patients lay in bed a lot. That's just because, you know, they're being managed more medically than they are about mobility. So once they get to us, you'll see pretty significant changes in their abilities pretty rapidly. It is a result of the increased movement and also the intensity of therapy, just being in therapy for 3 hours or more a day. In her case, and in patients that have speech, they'll get more than 3 hours of therapy a day. So they'll get 2 sessions of 45 minutes with PT, 2 sessions of 45 minutes with OT, and a 45-minute session with speech therapy. So they get 3 hours and 45 minutes of therapy a day. We wanted to give lots of education to her and her spouse initially. So I did extensive education on stroke pathology, neuroplasticity, and recovery post-stroke. And as far as gait training, she still was requiring, you know, once we first started it, 2 to 3 people, depending on the setup, use of overhead lift. And she always required a wheelchair follow-up for the first few weeks for sure, unless we were in the overhead lift. So we did improve her tolerance to upright. Her gait training got better, and we started using kind of different interventions to give her some more input on that side, which I get into more at the bottom. But she was getting more from a lot of assistance from 2 people to less and less assistance from 2 people to complete these salient tasks for her. So we continue to give as much feedback as possible, whether that be a mirror, weights on the arm or leg, TheraBand resistance, or like in the picture on the right, that's a TheraBand figure 8 pattern. So that allows for a increased dorsiflexion, increased knee flexion, increased knee or hip flexion, in addition to increased compressive forces at all those joints. So it gives her body or her brain more input about where that limb is in space. So family trainings for her occurred every Monday. Her spouse would come in every Monday afternoon, and we'd have an ongoing discussion about home setup, expectations, goals for mobility and assistance level upon discharge, an ongoing discussion of what durable medical equipment needs she would need. I will say it's a very tough setting to work in because the patients are going through the worst medical time of their lives generally. And also the caregivers are going through a huge adjustment period where they're likely going to have to care for these patients unless there are higher level patients. So you want to bring them in as much as possible to really set expectations and really get to know them really well. So you can have an open communication between you and that caregiver. So during week 3, the patient progressed consistently to min to mod for her low pivot transfers, those wheelchair level transfers. So then I upgraded her in the room with the nursing staff, and I trained the spouse to provide those, which gives more freedom and independence. Before week 3, she was in an overhead lift whenever she would get anywhere in the room. So she would lay in bed, they'd put her in a sling, lift her over to the wheelchair, and then sit her up. Because nurses aren't as skilled as us, and they also have like lifting requirements, if the patient is above a mod assist, we cannot allow nursing to do transfers with them. If they are a mod assist, it would be a min assist of 2 for the nursing staff. So either 2 techs or a nurse and a tech have to perform the transfer with the patient. On week 4, I provided printout of education of bumping up and down the stairs in the wheelchair with 2-person assists, and I did some demonstration and practice with the spouse and my rehab aide. And then week 5 is when we really got going, and she was doing her stand pivot transfers with a rolling walker in either direction. And the rolling walker also had a modified hand grip on the left with Velcro straps that she could put on, because she would oftentimes lose or because of the left inattention, not know what the hand was doing in space, and it would drop off and her whole trunk would turn over to the side, and that is not what you want when you're up and walking. So this was when she was more consistent with this. So we upgraded in the room and with the spouse. So she was allowed to move around more in the room. So these are some of kind of the early on neuro re-education interventions. We obviously did the treadmill training with her with an overhead lift. She was initially min to max of 2 for weight shifting and trunk control. Stand pivot transfers with those weights on the ankles and wrists. We started doing some curb step training with bilateral handheld assist in an overhead lift. And then we did utilize the Eva walker with her as well, because it allowed for more trunk control for her. So she could just push down through her whole forearms instead of just her hands. So then I went into some of my progress notes. I'm just going to kind of hit the highlights. The highlights are increased distance every time, less restrictive assistive devices every time, more stairs. So this one, you see, we only did 1 4-inch stair in two trials, and she was requiring mod assist and mod verbal cues. So you want to talk about like your verbal cues too. Plus, I had my rehab aide guarding her for safety just in case. But you do want to talk about verbal cues. What input are you giving to the patient for the patient to complete the task appropriately and safely? Because that's kind of grading what the patient needs for an insurance perspective and for how they're going to get home. She was doing stand pivot transfers at a mod to max level at that point. And then if you just go down, she's kind of performing min to mod for her sit to stands. Her bed mobility was getting a lot better, so I didn't have to be as close for her rolling. And her sit to supine, I believe I was just close supervision as well, but min assist to sit her back up from laying down flat. And then on the 6th, this is when we got a lot of the equipment. So I had consulted our wheelchair specialist from New Motion to come in and see her. And that's Carrie Queen from New Motion. She came in a week before this, I believe, or a few days before this, but provided us with that K5 loaner. So we did a full evaluation while she was with us, and they start building that wheelchair, but that wheelchair takes about 4 to 6 weeks to be built and customized for her. So they try to get our patients in a loaner wheelchair they can go home with and use while they're with us in rehab. She also got a left lower extremity molded ankle foot orthosis. So that's one that kind of captures the whole leg, and it's plastic, it's not carbon fiber. And that gave her more input about where her leg and ankle were in space. And it also, we also got it with a dorsiflexion stop. So it prevented the knee from snapping back as much. So it didn't throw her trunk off as much. Once we first put it on, it was great. We trialed some of our off-the-shelf carbon fiber ones, but because of her body habitus, she was a little bigger. She would walk right through them. So we needed something that was really stable, really had a lot of support, and really gave us what we needed to improve her gait mechanics and safety. So now we're really getting going here. She's walking 180 feet with this rolling walker with the hand grip that we made for her. OT made a customized hand grip. They molded it using our one of our hydroculators or one of our like heated water pad things. And then they put these Velcro straps on so she would always have that hand in there. And then we kind of use some Dysum and some other kind of stuff that we have available to us to make sure that really sticks onto the rolling walker. So she's really at a contact guard level for household distances already, which is like her long-term goal. And this is right near her discharge date. And she's contact guard to min assist for these longer walks. So as she would get more fatigued, she would sometimes lose the hand, or she would take some missteps, especially during turns where they would get a little too narrow, or she would place her foot in the wrong place and it would throw off her trunk a little bit. So just a little correction or steadying would help her. She was doing 12 stairs at this point at min assist level, which is kind of what we wanted to. She was at a stand pivot level, at a contact guard level. So we're already hitting we're approaching or hitting some of these goals. We really want the patient to be consistent before we say we met the goal, though. So sometimes we go back and forth depending on how they're performing day to day. So her final family training and her discharge summary were performed on October 21st and October 23rd. She met all of the goals that I had outlined for her. Her spouse was sufficiently trained, and all durable medical equipment was delivered and customized for her and made sure it was fit for her. Because we can only order one mobility device, I ordered the wheelchair, and because it was a K5 wheelchair, we have to write a pretty extensive letter of medical necessity for those. So it was about 8 pages. And luckily at our rehab center, generally our manager will let us block a 45-minute slot to write those, because they do take about 30 to 40 minutes to write. And we have templates for those as well. Her strength was symmetrical bilaterally. Her timed up and go score, so this is a standardized outcome measure that I couldn't do until closer to her discharge for safety concerns, did indicate an increased risk of falls, which is why she's going home with home PT, which is what the recommendation was. We set her up with home services initially. We generally want to see a tug score of below 13.5 seconds, and she was at 25.2. As far as gait speed, there's a lot of normative values for that. And generally, she fell in the kind of category that indicates limited community distance walking, which makes sense. She could do small distance walking, the 180 feet, 150 feet, but anything more than that on her own or even with somebody is very unsafe. So this is her victory lap. If we can get it up. I did send it to you, Tim.
Just give me a minute here, and I need to
No problem.
switch things around a little bit. Okay, this is a rock star. I'm going to. I'm being visually challenged right now. Hold on for a second. There we go. Share screen.
So you can see I'm always on the left side for that. And that AFO is under her pants at that point. But as she gets closer, you'll see the hand grip modification as well. She still had the trach in at that time. They didn't want to decannulate her until after she was discharged. And a lot of our staff came for this. So a lot of our nurses were here, which was wonderful. The doctors were there. Everyone was there. And that was our handshake that she came up with. And our patient care techs wear the all gray. Our nurses wear navy blue. We wear this Caribbean blue and black combination. So you'll notice in the hospital settings, depending on what profession you're in, you'll wear certain scrubs. Very emotional for these ones, especially. And Jess had a huge personality. But you can hear how she talks to her, the paralysis in her face from the facial nerve, or the trigeminal nerve, and also the vocal cord issue causes, a little raspiness. All right, that's fine, Tim. That was her speech therapist that started talking to her about a lot of swallowing issues.
All righty. Do you want me to go back to your presentation?
There was just references and questions, so
Yep.
I'm open for that.
Let's go into the questions. I've got 3 saved up right now. And for all of you students out there, this was more closely akin to the kind of education you'll get in the real world. A lot of our other presentations have been a little bit more light duty, but this was excellent, Colin, excellent, and very, very true to what you'd experienced. And one of the things that I was reminded is, just as in social media, we have, LOL and rolling on floor laughing and JFC and all sorts of other things that I shouldn't say. Well, medicine does the same thing. Medicine lives on acronyms.
Mm-hmm.
By the way, I should tell you that LSVT stands for Lee Silverman Voice Treatment.
Yes.
And now you know, and for some reason,
oh, I know,
really strange feedback suddenly going on. Anyway.
I thought it was about like a founding member of the program too, so that makes sense.
Yeah, so that's that. Well, so let's go right into one of the first questions was from, I can't even say your first name, I'm sorry. Is speech language pathology a subtype of physical therapy? And also, how much experience do you have in the field of SLP?
Speech language pathology is its own profession. So they go to their own school, and they specialize in speech, swallowing, and cog assessment and cognitive treatment. So they deal with a lot of that higher level stuff and compensation techniques if we need them. We sometimes get patients that are very aphasic, so they can't get anything out, and they really can't understand anything coming in as well. So we really rely on our speech therapists to come up with some type of compensatory strategy to be able to effectively communicate with the patients so that they can get home safely. And they can also use like specialized iPads where they can kind of push what they want to say if the patient is cognitively at a high enough level to do so. So for speech language pathology, you have to go to 4 years of school, and I believe it's a 2-year program after undergrad.
All righty. I'm going to ask 2 questions in succession, one from Madison, one from Jasmine, because they're the 2 sides of the coin. Do you enjoy your job, and what's the favorite part? And then from Jasmine, what's the most challenging aspect of your job?
Okay. I enjoy my job. It's very stressful. It can be very hard. I come home some days and I just want to lay down and go to sleep. I come home some days and I just want to cry. Especially during COVID, it was very hard for us. But the most rewarding part is what you just watched. We're taking patients that are at their lowest level and very, very impaired, and having them leave walking and having them leave to go home and have a higher quality of life, and then continue that recovery process. I will say with her, she's now getting to outpatient therapy because I'm following her care bridge and talking to her. She got her wheelchair delivered. She's doing just fine in the house. She's graduated from home therapy. She's really moving on. So these are the patients that were with me for like 4 or 6 months that I really follow up with pretty consistently and regularly, and that's very, very rewarding to me personally. And Tim, what was the last part of the question, or the last question?
Uh, well, what do you find most challenging? What do you find most rewarding?
Yeah. Um, yeah, and then most challenging too is we sometimes do get oncology patients, unfortunately. And if it's a brain tumor resectioning, sometimes the pathology report doesn't come back until they're with us. And then it can end up being a GBM or a glioblastoma multiforme, which is a very, very bad diagnosis. Most of the patients, die within a year. So you have to deal with those kind of extra interpersonal issues and emotional issues, in addition to just trying to get the patient up and moving again. And we have had patients die on our unit. We have had patients, we often have rapid responses that we have to call ourselves, or stroke alerts if patients have evolutions of their strokes or additional strokes during our care. So you always have to be kind of on the ball and very attentive with your patients.
All righty. At one point when you were doing the case, your sort of case review, you were talking about the scoring and how you handled scoring when a patient in essence refused or was not compliant with doing one of the things. And so the question is, why would a patient refuse to do one of the patient goals, and how do you functionally move forward from there outside of just the scoring thing? I mean, if a patient's non-compliant, how do you move forward?
So it is very it's very interesting. Sometimes the patients get to us and they don't know much about the program, which is completely unacceptable. We have liaisons that work at both our hospitals and one that travels to Unionville Hospital now, that are supposed to vet these patients and meet with them face to face and tell them exactly what the expectations are for coming to us. And I do that as well when I'm on acute care, and our therapists do that as well when our acute care therapists that are assigned to acute care do that as well. But sometimes we get people that come to us and they don't want to be there and they don't want to do it and they don't want to get out of bed, or they're having way too much pain. That, more understandably, are people that have too much pain, or they have cog impairments, or they're sundowning because of dementia. Sometimes you just have other issues to deal with, but there are the cases where you're just dealing with people that aren't nice and don't want to do it, and you're kind of just arguing with them. And we don't do that too long. We don't. If I'm going to your room and you're refusing me just because you don't want to do it, we're contacting social work and the doctor immediately. The doctor knows right away. We all have cell phones with Vocera, so we're paging the doctor immediately saying patient's refusing for whatever reason, and then they're going to work on a plan to get them somewhere else, whether that be a subacute rehab, or call the family and say, hey, you need to come get your patient, and they're going to require more assistance at this time.
All righty. Abigail asked, could pelvic floor physical therapy be performed by labor and delivery or postpartum nurses?
I imagine so. So there's lots of different treatment techniques within pelvic floor, the pelvic floor specialty, that can be delivered from non-PTs. I think PTs just get more specialized training when they go through those specialized training programs. But I'm going to assume labor and delivery nurses are already trained on some of the pelvic floor exercises, especially postpartum, to really kind of help that area heal after it goes through that trauma.
Right. And you know what? I'm going to put you just a little bit on the spot, and maybe just a minutia outside of your comfort zone. But can you explain to the guys in the audience what pelvic floor disorder, dysfunction, rehabilitation really means?
Yeah, so it's in both sexes. There's a group of muscles that are down there that control, relaxation, urination, erection, sexual function, all types of things like that. And what pelvic floor specialists really do is work to get those muscles to function appropriately again, or to build the strength back in those muscles so that the activities that are being limited or affected by the dysfunction can get back to normal, essentially.
Right, right. And then a different Abigail asked a real zinger of a question. How does your approach to physical therapy differ when working with neurological conditions, particularly in contrast to conditions where the benefits of physical therapy may be more visibly evident? That is a high-end question, Abigail.
Can you repeat that for me, Tim?
So if you go to Q&A,
okay,
you'll be able to.
Well, I find working with neurological conditions to be very visibly evident. It's probably the best. So my favorite patient population is stroke patients because you see a lot of recovery early on. Within the first 30 to 60 days, actually within the first 60 days, you're going to see the most recovery. And then it's kind of teams or straightens off from there with stroke patients. With other patients, you can maybe not see recovery. With our traumatic complete spinal cord injuries, you're thinking only compensation, right? So I talked a little bit about the recovery versus compensation spectrum earlier. You always want to think about where your patient lies on the recovery versus compensations spectrum, and then go towards that. So if the patient is going to require a wheelchair and require leg loops to move their legs because they're a complete spinal cord injury, you want to start practicing that initially, and that's compensation. If you think they're going to regain their strength to be able to move their legs on their own, like a stroke patient, you want to get to the recovery and have them try to do that on their own as much as possible. So with neurological patients, most of the time, you're going to see good recovery early on.
Right. And then this is a question that I'll answer. Question is a 3.8 GPA good to become a nurse, or do you need a higher GPA?
That sounds like a great GPA.
Yeah, that is a great GPA. And here's the deal: you can have a 4.0, you can have a perfect GPA, but if you don't have it balanced with extracurriculars, with shadowing, with experiences like mini-med, you'll just be another 4.0 GPA student competing against a lot of other 4.0 GPA students. So it's more on having academic achievement, but also having all those other components, and anything that sets you apart and different is always, an advantage that you can work with. So, for those of you who have asked, can I use my mini-med certificate, as part of my college entrance? Absolutely.
Mm-hmm.
Now then, for other people who are asking, how long will the certificate take if it's self-signed, and how long will it take if it's going to be signed and whatnot? I'm going to give you as good of a answer as I can, and then I have a final question for you, Colin. The self-signed certificate, you will be invited, and you have to, in fact, complete a survey before you will get a link to the self-signed certificate. We'll only send that to those of you who have attended fewer than 6 sessions. For those of you who have attended 6 sessions, the whole series, you will get the signed certificate. That will be mailed to you. You should not look for that until the 3rd week in January. We've got the winter holidays and a week off coming up, and the U.S. Postal Service is not as fast as it used to be, and it's a little bit of a process to produce them. So it will be the 3rd week in January. For those of you who really wanted to get the signed certificate, however, you missed a session for whatever reason, go ahead, and when we send out the email about the next mini-med, do a makeup session, or 2 or 6. But then you'll have enough to get the signed certificate. For those of you who want to join the Youth Medical Academy, then you'll do the reflection paper, and we'll reach out to those of you who qualify for that, with an email. So, and yes, if you miss one session for the South meetings, can I still put it on your resume? Yes, of course you can, because you'll still have the self-signed certificate, and we'll have a track of it. So, Colin, in 1969 is when biofeedback was quote unquote discovered. In 1977, I started my undergraduate work, thus dating myself terribly. But in any event, biofeedback back then was voodoo. It was almost too good to believe, except being a biology major, I got to play with it a lot, and my gosh, it worked. And so now we progressed up to, we've got not only biofeedback as a routine part of clinical care, but we also, there's the consumer side of it now with Peloton and wearable devices. And now we bring in machine learning and artificial intelligence and whatnot. Do you have any thoughts about where PT might be going relative to, ever advancing technology? And how might your role as a physical therapist need to adapt to ever more complex technology solutions? Sorry, that was a hell of a big question. Sorry, buddy.
Oh, I love that question. But to go back to your point before that, it is very important to do all your extracurricular activities, do all your observation hours. It's almost like Tim said, it's more important than your GPA. Your interview for your school is going to be more important than your GPA. They want to remember you. They want to know why you want to go into this profession. And to your question, it's always changing now for us. And there is more equipment coming. I wish we had more funding so we could get more things and more adaptive devices to give more biofeedback to our patients, to give more input to the central nervous system so we can allow those reconnections and rewiring of the brain and the spinal cord to occur so our patients can have better quality of life and better functional outcomes as a result. As these technologies come out to us, we are constantly being trained. We are constantly training each other. We're constantly challenging each other. As part of our role in the rehab, on the rehab team, we stay involved in journal clubs. So we do journal clubs typically once or twice a month. We have in-services all the time. So our lunch is from 12 to 1. Usually we have in-services from various providers, various vendors from 12:15 to 12:45, always learning more about what we need to do or getting more information about new technology. We just recently had someone come in, a complete spinal cord injury, and a vendor of an exoskeleton with an exoskeleton, and showed us how it functions, showed us how he uses it when he's in his therapy sessions and the benefits for him. I always think it's important subjectively to hear from the patient about how they feel about a device before we necessarily spend a lot of huge capital budget on something like that. And it is, for something like that, you need to be considerate of all the things that go into it. The training for our staff, the time that's required to set it up, the effectiveness of it as far as research and outcomes is what we really want to know about, right? And that's how we are as kind of scientists. What is the research, or what is the data telling us about these technologies? So that's why we always want to kind of inwardly look back and say, is this effective for the patient? And then also objectively, how is the patient enjoying it? Because some of these things, these patients buy at home. They'll buy standers, you can get a Bioness L300 at home, and patients oftentimes use it. Now, insurance generally doesn't pay for it unless under certain circumstances. But I have seen, even this past summer, a patient that looked like an MS patient using the lower leg cuffs on the beach to be able to get the dorsiflexion to clear her foot from the sand. So you do see this in practicality as well.
Right. All righty. Well, Colin Burke, Dr. Burke, thank you very much for an outstanding presentation. And to all of you on the other side of the Zoom session, no matter what holiday you're celebrating or not celebrating for that matter, happy holidays to everyone. Happy New Year. And you'll be getting emails from us about one thing or another, depending on how many sessions. And Christy, any final words from you?
No, I just want to thank you, Colin. I really appreciate you being here with our group this evening, and happy holidays to everyone.
All righty. Take care, everybody. Talk to you next year.
Thanks, guys.
Bye.